Hello, everyone. I'm Dr. Angela Fitch with knownwell, and we'll just give everybody a chance to get into the webinar. I just wanted to get it started a minute before 4 p.m. here on the East Coast, and just wanted to give everybody a minute to jump in here before we get started. Thank you for joining on this lovely Monday in the summer. So great that everybody could be here. Just another minute before 4, and we'll get started right now, actually, because it's 4 o'clock. Hello, Hanover County. I am Dr. Angela Fitch, the co-founder and chief medical officer of knownwell, and I'm excited to be here today to talk about understanding obesity medications, what you, as a potential patient or loved one or caregiver, need to know. I am going to go ahead and remind everyone that there is a Q&A button, or maybe it's a chat. Let me see here. We have a Q&A. So if you want to put any questions into the question and answer button at the bottom of your Zoom, please do so as you think of them, because we will have time for questions at the end for those of you that are attending live. And the audio is echoing, someone says. Okay, well, maybe, hopefully it'll adjust a little bit. Is it echoing for others? Hopefully not, but hopefully it'll settle down, or maybe I can just not talk as loud. I'm kind of a loud talker, one of those loud talker people. So I'll try to talk a little bit less loud, and let me know if it still is a problem, please, for others. All right, let's get started. Understanding obesity medications. Again, I'm Dr. Angela Fitch. For those of you that just joined, I'm the co-founder and chief medical officer of knownwell, and we will go ahead and get going. All right, so knownwell is the preeminent nationally scaled provider of obesity medicine and metabolic health care. We have a comprehensive care model. We have some of the industry's most leading expertise as far as our clinicians are concerned, and we have some superior clinical outcomes we'll share with you at the end. So first of all, let's talk about weight management in general, right? Why is lifestyle alone often not enough for treatment? And again, let me just hold on a second. I just realized something. I think I grabbed the wrong deck. So let me just stop here. I got a different deck. I'm going to reshare. I apologize here, everyone. Um, and let me just grab it. Okay, hold on. Alrighty. Really, a little bit of technical difficulty here. All right, now I'm good. All right, just didn't want to have the wrong one for you guys. All right, now here we go. Did I lose the webinar? Uh-oh. Hold on, guys. Apologies. All right. And one more button here. Okay, now we're cooking with gas. Okay, apologies there. Had the wrong deck up. That's a problem working on multiple things at once. So here we go. Taking off where we left off. All right, this is where I wanted to be. First of all, we need to recognize that obesity is a chronic treatable disease. Obesity is a disease in which excess body fat has accumulated in a dysfunctional manner to a level that may have an adverse effect on health. So I highlighted those things in red because it's really about those things. You'll notice in the definition of obesity, nowhere does it say anything about weight. Yet that's what a lot of us put a lot of a lot of effort on is a number on the scale. And it's really not about a number on the scale. That's what we really want to level set on. It's really about our biology as humans. It's not just about our BMI, which is our body mass index, right? Which is a number that was never meant to be assigned to an individual person. It was meant to be a screening tool used in epidemiology to say if your BMI is higher than this, then you might have more problems or more health conditions associated with that extra adiposity. Adiposity is the fancy word for body fat. And so, again, obesity is a disease in which excess body fat has accumulated in a dysfunctional manner. It's dysfunctional. Patients don't want it to accumulate, and it's not their fault that it's accumulating, but it may have an adverse effect on health. And this is what we really want to level set on as we talk about obesity. And the causes of obesity are complex. In the center, there is of this diagram here, you can see that it has said uh, energy balance. If you look at the center of this slide, it says energy balance. And that is really what it's about, right? Calories in and calories out are what we call energy balance. It's how much we eat and how much we expend. And this has been discussed for centuries that it is just about eating less and exercising more, but it's not. That's what this slide is trying to show. Yes, we do have to expend more energy than we take in order to lose weight. But the point of this slide is to show how complicated that really is. It's not as easy as eating less and exercising more. It's actually very complicated because all these lines you see under the big colored circles are all reasons for why our body tends to gain weight, right? It's about our biology, our eating behavior, our physical activity, yes, but it's also about our food production, psychological issues we may have. It's about the built environment. The built environment means the environment that's around us by nature that has us sitting at a desk potentially as our job, right? Having to work at a desk job. These are all things that, while we can work on being more physically active, the environment sort of leads us to this condition that we're in right now. And all these things together make it very challenging to lose and sustain weight loss long term. The obesity prevalence is increasing in our country. By 2030, it's expected that over 50% of the US adult population will have the disease of obesity. You can see here in 2020 to 2030, where the areas of darker red are up to even 60% prevalence of people having obesity in those areas that are darker red. We don't know why some areas, for example, you might notice that Colorado is the very square state that sits sort of almost in the middle of the country there, is quite yellow and has been yellow or has had lower obesity rates for quite some time. And it also has, even though it's getting a little bit more orange there, you can see it does have lower rates. But again, that doesn't mean that the Coloradoans are any better people than the rest of us. This is just epidemiology about where the disease of obesity is. And so let's talk a little bit also, though, about metabolic health, because we hear this a lot too. Metabolic health, our metabolism, the health of our metabolism. You can see I kind of put this analogy as these two cars, right? Metabolic health is how smoothly your body's fuel system or your body's engine runs. When it runs efficiently, you feel steady energy and your long-term disease risk is lower. When it doesn't, the engine starts to strain. You can see this sort of old sluggish metabolism as this, old sort of rusty car from the old days. But now we have this elite metabolic health in this sort of race car that's been highly tuned and highly engineered to be very, to run efficiently. If you're metabolically healthy, your body keeps your blood sugar in a normal range without big spikes or crashes, maintains healthy cholesterol, triglycerides, has normal blood pressure, tends to store fat and use fat appropriately. This dysfunction I talked about, that dysfunctional storage, is really a manifestation of issues with our metabolic health. When your metabolic health is in good shape, it responds well to insulin. Insulin is the hormone that moves sugar from your blood into your cells. And when you have insulin resistance, that can lead to excessive weight or fat storage. And we'll talk about that in a second. But what factors affect weight change and metabolic health? We saw that complicated graph, with all those lines, all those intersecting lines, and certainly all those things play a role, right? But also our genetic predisposition. That's that part of that earlier slide where we talked about biology, right? Our genetic predisposition is something that really is something that leads more people to have the disease of obesity. There are neurobiological factors in our brains, and we're going to talk about that in a second more. There's also psychological factors, as I mentioned, socioeconomic status, energy intake, and energy expenditure, right? All these things come together to play a role as it relates to our weight management, but also the health of our metabolism. If you have metabolic syndrome, this is a syndrome that a person can be diagnosed with when they have three or more of the following things. If you look at the things outlined in red there, three or more of those then say that you as a patient, as a person, have what we call metabolic syndrome. This is interconnected pathways that we're now calling cardio-kidney metabolic syndrome or cardio-kidney metabolic disease because it doesn't just affect your metabolism, it affects your liver, your kidneys, and your heart. And that's again why we're putting so much focus on this is not because we want a person to lose weight, but we want a person to have healthy organs and live longer and have longer function of these organs and protect the function of these organs long term. That's the main goal. We say often at knownwell that we do these things for the health of it, not the weight of it, right? It's not about what you're going to lose when you're going into treatment, but it's about what you're going to gain, gaining health, not just losing weight. And again, if you have three or more of these things, abdominal obesity, so an increase in your waist circumference, and that's measured with a tape measure over the largest part of your abdomen, not like maybe down low where you might wear your pants, but the largest, roundest part of your abdomen. If it's greater than 40 inches for men and greater than 35 inches for women, and there are also ethnicity specific cutoffs that are lower for people of Asian descent, for example, but that would be a criteria with this abdominal obesity. Elevated triglycerides, a low HDL, which is your good cholesterol, an elevated blood pressure, or an elevated fasting glucose. If you have any of these things, if you have three or more of these things in particular, then we say you have metabolic syndrome. Insulin resistance is a piece of that metabolic syndrome that leads to that elevated glucose. And what that means is for a lot of people, whether it's genetic or just as we age as well, that also changes our insulin sensitivity, especially for women as we go through menopause. We eat food, we make insulin. Insulin's the hormone from our pancreas that controls our blood sugar from that food we ate. But unfortunately, what happens as we develop insulin resistance is our cells resist that insulin. They say, wait a minute, I don't know what to do with this. I'm resisting this. And then they tend to store that sugar as fat instead of burning it right away. And so when you put something into fat storage, it's harder to get it out of fat storage. It's harder to get rid of that. It's better to sort of be really efficient and burn that energy as you're sort of eating it, right? Or as you use it. But because of that resistance, those cells resisting that insulin, it makes that sugar go into fat storage. And then you feel tired and hungry because your blood sugars go down too quickly. You have a spike up and down of your blood sugar. That makes us feel tired. That makes us feel hungry again. And then that can lead us to eat again, to snack again. This is a sort of a vicious cycle of insulin resistance that we can break with medication, but we can also break that cycle of insulin resistance with different behaviors as well. For example, taking a walk after you eat can help increase that insulin sensitivity. Even if it's a short walk or walking around your apartment or walking around your living room if it's too hot, outside at the moment. Dancing in the living room, right? Like no one's watching. These are the things that you can do in order to help improve that over time. And here's where I kind of started earlier on a different version of this deck, which is to talk about why lifestyle alone is often not enough for treatment. A lot of times people say, well, I don't want to be on a medication. No one wants to be on medication for any health condition. But when we know a medication might be necessary, is why then we might start a medication. Just like we take medication for our blood pressure, we don't want to do that, but we recognize that our blood pressure is high, and if we don't treat it, there are consequences to that. The biggest thing you have to understand is that losing weight is abnormal. It is not normal for the human body to lose weight. It's not engineered like those cars I showed you are engineered to race or run around the track or drive you to your next location. Human bodies are engineered to gain weight. They're not engineered to lose weight. You don't expect those cars to fly. You expect airplanes to fly because they're engineered for flight. Our bodies are not engineered to lose weight. They're engineered to gain weight. And so when we try to lose weight, as depicted in this tug of war here, when we try to lose weight, we decrease our calories, we increase our activity. This, unfortunately, what happens is it slows our metabolism, it increases our hunger hormones, and our body decreases our fullness hormones. And that, sorry, that's kind of advancing there, that pulls our body, pulls that weight back on, which is why we need the medications and surgery and procedures sometimes, right? In order to help on that other side of the tug of war. And this is why it's so challenging, right? This is not meant to be a test or anything. I know it's kind of complicated looking at, biological drawings that I would normally show my students, but this is there to sort of help me describe to you that this is controlled by the place in our brain called our hypothalamus. That's right there in the center of our brain. We don't control that place in our brain. We can't control that place in our brain. And that dictates our metabolism based on these interactions with our hormones in our gut, the hormones in our pancreas, as I mentioned, and even our fat cells themselves release compounds that interact here in order to promote that weight regain. You might recognize some of these what we call incretin hormones or nutrient stimulating hormones down here, such as GLP-1 and GIP, because now we have medications that mimic these naturally occurring hormones in our body in order to have a positive effect, right, and give more on that weight loss side of that tug of war. If we just blow up that hypothalamus a little closer, you can see here where we have these neurons in our brain that interact with food intake and decrease food intake. So increasing food intake and decreasing food intake. And they balance each other. And so again, we can manipulate those if we are using medication to do so. Obesity management medications are indicated as an adjunct to nutritional, physical activity, and behavioral therapies for patients in particular that may have a body mass index greater than or equal to 30 or a body mass index greater than or equal to 27 with some sort of other complication of obesity, some sort of comorbidity like high blood pressure, high cholesterol, sleep apnea, fatty liver disease, etc. So these are our indications. This is what we have studied these medications in these populations of people. And the medications themselves do multiple things, right? Listed here. They treat the disease of obesity. They facilitate the management of our eating behavior as humans. Some people also have psychological overlays to their eating behavior that also may be difficult to control, even beyond just their biology, as we talked about before. They can also slow the progression of weight gain or regain. For some of our patients, they may have lost a significant amount of weight with lifestyle modification alone. But again, as time goes on, we can see that weight come back on. So for some patients, it's about preventing that weight regain, even as the goal. But most importantly, they improve the health, the quality of life, and of our patients with overweight or obesity. So again, it's about this health of it, not the weight of it, that we do these things because we know that even a 5 and 10% weight loss can improve both metabolic and what we call fat mass disease. Fat mass disease is more like just your weight in general, right? If you have excess weight, it puts extra force on your joints. So you may have knee pain or hip pain or back pain. That's really more just due to that extra weight, right? Whereas if we look at what we call sick fat disease, that's where people are getting metabolically unhealthy, things like the insulin resistance, etc. And here's just a little more, again, very similar to that other slide. And I show this again, not because there's a test at the end or anything like that, but because it highlights where all of our different medications, if you look at all of these square boxes, they are the names of different medications. And these are where all these medications act on these centers, areas of the brain and the hypothalamus in order to change our eating behavior subconsciously, so to speak, in order to promote that weight loss, in order to tug on that other side of the tug of war so we can continue to maintain that weight loss or we can continue to lose weight. We also see that our medications, especially what we call our GLP-1 or our incretin type medications here. This just lists liraglutide and semaglutide as examples, but they also are effective in our gut as well as in our brain. So they work in both places, which tends to make them more effective for weight loss or why they're more effective for weight loss. Here you can see this is just a highlighted example of our GLP-1 type medications or our GIP type medications that help what they do in our bodies, right? So GLP-1 receptor agonism, when we activate the GLP-1 receptor in our body, which again, we have naturally occurring GLP-1 in our bodies all the time, but we accentuate it when we take a medication. And what that does is it increases our satiety, our feeling of fullness. It decreases our food intake. Unfortunately, it can also increase nausea as a side effect. It also can increase insulin production, decrease glucagon, decrease the emptying of our stomach. And some of these purple things are what happen as another side effect, right? Which most importantly is to increase the insulin sensitivity of our liver and our skeletal muscle. So we are using that, improving that insulin resistance secondarily. GIP is another receptor in our body, right? And so now we have medications that activate not only GLP-1, but also GIP. And you can see what GIP does as well. And one of the things that GIP does is it decreases nausea. So it's one of the reasons why we think the medication tirzepatide, which is also known as Zepbound or Mounjaro, has a little bit better side effects because when you activate GLP-1 with something like semaglutide, for example, which is only a GLP-1 receptor agonist, you get some nausea as a side effect. When you add a GIP to it, which is tirzepatide activates both of this green and red receptors, right? You can get a decrease in nausea. So again, that's one of the reasons, that's how these things are working in our bodies. So Wegovy is semaglutide. It's a protein peptide that activates GLP-1, right? So semaglutide is one of our first more effective, or what we call second generation medications for obesity, because it did have a significant increase in efficacy. A peptide is a short chain of two or more amino acids. The amino acids are the building blocks of proteins, right? This is a protein molecule. This is what it is. That's it right there, which is all those little round balls are the different amino acids that form it in three dimensions. You can see it in one dimension at the top of the screen, but it's linked together by these chemical bonds. So Wegovy is a protein peptide, and that's one of the reasons that it has to be specially formulated for us to be able to take it orally, or one of the reasons why most of the time in the beginning it came as an injection until we could figure out how to administer it orally, because it is a complex protein that's hard to get into the human body without injecting it. That's why most of these medications are injections. Although we'll talk later, we do have oral Wegovy now, but it's specially formulated in order to get it into the human body. Zepbound is tirzepatide. As I mentioned, it activates both GLP-1 and GIP. So you get the red things, right? And you get the green things. Red and green are not meant to be negative or positive, right? They're all both types of effects. But the idea is you're activating both GLP-1 and GIP with tirzepatide now. You can see where it's the same molecule. It's one molecule called tirzepatide, but it binds this GIP receptor as well as this GLP-1 receptor on the cell membrane. And then that has these beneficial effects that we've talked about. Because it binds these two receptors instead of just one, is why the weight loss power of tirzepatide is higher, right? It is associated with more weight loss. As we mentioned, we're doing this for the health of it, not just for the weight of it, right? It's about a percentage of weight loss. It's not about pounds. It really is about a percentage. So if you think about it, if a person weighs 250 pounds, 20% weight loss would be a 50-pound weight loss. 20% of 250 pounds is 50 pounds. So if you weigh 250 pounds to start and you lose 50 pounds, you still weigh 200 pounds. You might think that you would like to lose more. But the point here is that losing 20% of your weight has significant benefits to all of these diseases listed here. Prevention of type 2 diabetes, remission of sleep apnea happens at around 15% weight loss. Improvement in physical function starts very early, but we get significant improvements as we get into that 20% weight loss as well. We get remission of fatty liver disease. We can get type 2 diabetes remission at that 20% weight loss. We get a cardiovascular risk reduction, that's what MACE stands for, and a cancer risk reduction starting into that 20 and 30% weight loss. Those conditions at the bottom, the more weight loss we can get, the more reduction in those more serious things like cardiovascular risk reduction, heart attack, stroke risk reduction, and cancer risk reduction, which are certainly harder, to get those types of benefits. As far as treatment goes, we have multiple treatments that we employ, and we employ them together. This is a pyramid, but it's not meant to be something you have to crawl up to the top, right? The idea is on the left-hand side, as you may have increasing health risks and increasing adiposity, that's the fancy word for that excess body fat, right? As you have increasing body fat, increasing health risks, we have to sometimes increase that treatment intensity in order to reach one's goal. Because on the right-hand side here, you can see the average weight loss that we expect from each intervention. So lifestyle modification, it's very important for all of us, no matter what our body size is, to do lifestyle modification because moving more, eating more vegetables, de-stressing, that shows a person like kind of doing yoga there, sleeping well. All of these behaviors are important to us for our longevity, no matter what our body size is. Unfortunately, those behaviors alone, lifestyle modification alone in those programs, show about a 2 to 5% weight loss on average. That's not because they're not good for us, but it's because they're not very powerful as it relates to helping to lose weight because of that tug of war that I showed you. Because the body is constantly trying to put that weight back on. When we make lifestyle modifications in order to produce weight loss, our body is literally fighting back, saying, wait a minute, she's not supposed to lose weight. I might be dying in the wilderness. I'm going to have her put that weight back on. And that's why the average weight loss is only around 2 to 5%. If we look at these other treatment options, we have prescriptive nutritional interventions. These are things like a meal replacement program or a structured eating behavior. Like for our patients at knownwell, some patients do choose this, especially if they don't have access to medications, because you can see it gets about a 5 to 10% weight loss on average. This is where you might have a shake for breakfast and a bar for a snack and another shake at lunch and maybe a salad. And then you have a lean and green meal for dinner, whether you're making that yourself or getting that, from a packaged service so that you can try to be more prescriptive about how you are getting your nutrition. When we do that, we do see greater weight reduction. And then we have pharmacotherapy with 10 to 25% weight loss on average. We have endoscopic procedures now. These are procedures performed with an endoscope without having to have, things, surgery from the outside, right? This is surgery from the inside. And then we have bariatric surgery at the top of the pyramid because it still produces the most weight loss on average and is the most durable without the side effects of medication. So for some patients, that is what they might choose. So let's talk about the current medication option, what's approved today, and how these agents or how these treatment options for medication for weight management and metabolic health improvements compare. So here are our current medications. On the left-hand side, you have the FDA-approved medications for obesity treatment. On the right-hand side, I've listed what we call off-label. That means in medicine, we use a lot of things what we call off-label, meaning they're not approved specifically for weight management, but they may have a positive effect. An example there is metformin. Metformin is approved for diabetes, but it also helps with insulin resistance. Same with SGLT2 inhibitors. They're approved for diabetes, but they are also been shown to help with that insulin resistance. So if we can use one of those and have coverage for one of those, that can help people along with that lifestyle intervention. We also have medications like bupropion and naltrexone. You'll see over here on the left-hand side, the combination agent, the combination of naltrexone and bupropion as Contrave is approved for weight management. Literally, the company stuck both of those together, put them in one pill, those two drugs, and that is approved for weight management. The individual components are not technically approved for weight management, but we can prescribe them, same as we can prescribe them, together in one pill, and it really is somewhat of the same thing. The combination product is a little bit better because it's controlled release, so you get a little bit more steady release over the course of the day. But again, we can sometimes for patients, especially if they can't afford the combined medication, prescribe them separately because they can be covered for other reasons, by a person's insurance. So that's how we tend to do this to help patients get optimal treatment that is affordable and cost effective for them. Now, this slide is a little bit complicated. I don't want you to be overwhelmed by it. I want you to look at this 20% weight loss line. So this is the percentage weight loss that a person can lose with each of these interventions. And I highlight this because there may be many people out there that have lost greater than 20% of their weight. So for example, the patient who's 250 pounds loses 20%, which is 50 pounds. So now they weigh 200 pounds, right? And they may have done that with lifestyle modification alone. That's this first column. But only 10% of people are able to do that. So it's not like zero. I mean, good for the 10% that have done that. You might be one of them sitting out there right now listening that has been able to lose 20% of their weight and keep it off long term, but it's only 10% of people that are able to do that. 90% of people can't do that, and that's not because they're doing it wrong. It's because they're not a responder to lifestyle intervention. They're not a responder to that treatment. If we look at surgery, 72% of patients 10 years after surgery still have greater than 20% weight loss. That's why it's still the most robust treatment that we have to be able to offer patients a long-term strategy that doesn't require medication. Oftentimes patients with surgery do experience some weight regain and add on medication to help them stay down there. But again, 72% of people are still have greater than 20% weight loss at 10 years after surgery. And then we have all of our medications that I listed here. And two things I want to point out is that if you look at the red numbers, those red numbers are when we combine the medication with intensive lifestyle intervention. That's meeting with the dietitian regularly, potentially meeting with the health coach. So the more intensive of a behavioral therapy you combine, especially with some of these older medications, can help get more patients into those weight loss categories. But let's just look across the board. The first medication here is tirzepatide at 15 milligram dose. 63% of patients, or 63 out of 100 patients, are going to be able to get to that 20% weight loss. That's why it's so that's why it's so much in demand on the market, is because it is so effective at helping people achieve that 20% weight loss goal versus 10% with lifestyle intervention alone. So you go from 10 out of 100 people getting that with lifestyle to now 63 out of 100 being able to achieve that same goal with that addition of medication. With semaglutide, it's 36, close to 40% of people getting into that 20% weight loss category. With oral semaglutide, about the same. So whether you want to take a pill or take an injection, a pill every day or an injection once a week, you have that choice because it's about the same odds. 30, 36, a little bit greater with the injection, but about 30% of people, 30 out of 100, can still get that 20% weight loss with that pill today. So again, just an idea to help you understand how we help patients decide, what's going to be the best treatment for them. This is just highlighting the lower percentages, 5 and 10% weight loss, because again, it just recognizes here, if you look at this lifestyle modification category, only about 25 out of 100 people are going to be able to get even a 10% weight loss, which would be at 25 pounds for that patient that weighs 250. So again, it's hard to lose weight, is what I'm trying to say here. It is hard, biologically challenging to get sustained weight loss with lifestyle intervention alone. It's not impossible, but it is very challenging for the majority of people. And if you're not in the 25%, I don't want you to feel bad. It just means that you're not a responder to that lifestyle intervention treatment, to that treatment, if you will, medication, right? If you think of lifestyle intervention as a treatment or as a medication. These are the GI side effects of the four most common GLP-1 medications on the market. Liraglutide, which is our older medication called Victoza or Saxenda, and then semaglutide, which is Wegovy or Ozempic. Tirzepatide, which is, as I said, is Zepbound or Mounjaro, and then orforglipron, which is our new oral medication called Foundayo. And so you can see that across the board, the nausea, vomiting, diarrhea, constipation, they're pretty much the same, although you will notice, as I mentioned earlier, that tirzepatide has a little less vomiting and a little less nausea. These are color coded, so the darker red, the more side effect versus the lighter colors, right, the less of that side effect. And that's again just to help us, try to have discussions with patients because somebody may have quite a bit of constipation at baseline. So maybe we're trying not to make that any worse. And so trying to pick what treatment might be the best for them is how we might use this data. So at knownwell, we provide longitudinal metabolic care for patients. It's really about getting patients access to care, not just access to a medication, because that's what it's really about, right? This is a long-term chronic condition we want to help you manage across your lifetime. We do that with comprehensive evaluation of not only metabolic health, but also your condition, you as a holistic person, right? What are some of the issues that you may be struggling with? And we have all interventions available. Obesity medications, nutrition coaching, movement, lifestyle intervention, and health coaching. All of these things we can put together to optimize your care because the goal is to be able to have the best affordable long-term treatment overall. And the way we can help is that we have a full team with registered dietitians, health coaches, clinicians that can prescribe medications, GLP-1s and other medications, as we've talked about. We have meal replacement programs that our dietitians can help with, that prescriptive nutritional intervention, that purple bar that was one step above just sort of general lifestyle intervention. We have an app that we use called RX Food, which uses artificial intelligence to calculate, what your nutrition looks like so we can make sure we optimize not only your calories, but also your macronutrients. That's things like fiber and protein, but also your micronutrients like calcium and vitamins, etc. So using that can help our dietitians to be able to fine tune things for you a little bit better. We have frequent visits to check in for accountability that are covered by insurance. Unlike other places that charge a membership fee, we don't have any membership fees to join us. We're not like a subscription. We are seeing you for a visit and then billing that to your insurance, for which people do have a copay. We have cash pay pricing as well for patients that may not want that to go to their insurance if they have a high deductible. We deliver care in 50 states virtually, which would be for you all in Hanover County. But we do have clinics in six states across the country as well. If you have relatives or friends that live in one of those states listed, we have clinics as well. And how we do that is kind of set out here, right? We have a weight management visit every month for the first 6 months with our clinical team. And at that same time, have 3 or 4 registered dietitian visits over the first 6 months as well. And then, we space that out a little bit to one weight management visit every 3 months ongoing, and then one weight management visit every 6 months, kind of slowing those things down, but also having those dietitian visits in there too to provide increased accountability for you as the patient. And just a brief word on nutrition for those of you wanting to work on things after the talk today. My biggest thing on nutrition is for health is to crowd in, don't cut out. Don't focus on, I'm going to stop eating this, that, or that. Focus on, I'm going to add in more vegetables. I'm going to add in more fruits, more antioxidants, more colorful things, right? They have antioxidants in them. Blueberries, for example, have anthocyanins in them. This is an antioxidant that's very powerful from a cardiovascular disease risk reduction. And so again, think about how can I add in more of these things versus cutting these things out. Half of your plate should be vegetables and fruits, and then a portion, a smaller 1/4 of whole grains. These are things like brown rice, quinoa, etc., and then healthy protein, right? And beans and lentils as well, right, can fit into that category. And this, if you want to take anything home today, I'd say it's this as well, which are my 5 Ps, right? I made this up for myself because I wanted to remember things on one hand, right? So when I talk to patients, I can remember what to talk about. And these are all the lifestyle things. You don't have to make lifestyle modification too challenging or too hard, right? It's about planned portions. Plan out what you're going to eat. If you don't plan, you're left to the devices of the vending machine or something, downstairs, in the food hall, and that is you're usually not going to make a very good choice when you're faced with those things. So the more you can plan consistent, regular eating, portion controlled meals, the better off you're going to be. Every time you eat, say to yourself, am I eating a plant? Am I eating a protein? Right? And if you are, you're doing a really good job. If you're not, think about how you can add one in. For example, you might be eating some yogurt for breakfast. That's a good source of protein, right? But can you add a plant in there? Can you add some blueberries in there? Can you add some almonds, some nuts? That's going to add a plant right on top of that protein. We want to strive for 1 to 1.5 grams of protein per kilogram of body weight as a goal throughout the day, and that is what we strive for. You want to try to do power, some sort of resistance activity or training. That's me there in the gym here in Boston. And, doing some sort of power training twice a week is very good for your metabolism. Pillow, sleeping well is very important for our metabolism. It cannot be understated. So you want to get adequate sleep. You want to get good sleep. You don't want the cat jumping on you or the kids jumping on you as much as you can control that. I know that's why it's hard, I think, for a lot of times when we have young kids, especially for us to maintain our weight because it is challenging to get good sleep. And then pause. Pause just means avoid eating in the night for one thing, but also reduce your stress, right? Do something to try to reduce your stress, whether that's yoga or meditation, etc. Just breathing right throughout the day, taking a few deep breaths when you have a minute, that can also be stress reducing as well. All right, so moving forward with our medications, because this is the good stuff here. Beyond weight, our indications for medications are expanding. So for semaglutide, which is Wegovy, there's a cardiovascular indication to prevent a second heart attack or stroke. For tirzepatide, there's a sleep apnea indication. For Wegovy, there's also a liver indication for metabolic associated steatohepatitis or fatty liver disease. And for some patients with their insurance may cover these medications for these secondary indications if they don't cover it for weight management. And so that's why it's important, why we work to identify these conditions, also because they're important for health, but because it may provide access to patients with these conditions. Here is the cost of semaglutide from a cash standpoint. You can get this at NovoCare. NovoCare is a pharmacy that Novo Nordisk has set up to be able to do delivery in 50 states across the country. But you can also get these prices, these cash prices at your local pharmacy with a coupon. So the Wegovy pill is what's at the top. There are 4 different doses. Typically, most people are going to need to escalate to the 25 milligram top dose in order to get that average 15% weight loss. So that's the average weight loss with Wegovy, around 15%. That's $2.99 a month when you get to that highest dose. And so that's $10 a day, essentially, for that treatment, if you think about it in dollars per day. And I put it that way because many of my patients say that they are not spending as much money on food, or maybe they used to go to Chipotle or something for lunch every day, or wherever they might have gone for lunch, and now they're able to pack a smaller lunch and save that $10 a day, so they're able to afford it. Even though obviously we would love for everybody to have access via their insurance, but again, if you don't have access, it can be affordable for some patients to be able to figure out, where am I spending $10 a day, and can I really shift that over to this medication? For the injections you see below, Wegovy's on the right. There are 1, 2, 3, 4, 5 doses shown there up to the 2.4. But now we also have 7.2 milligram Wegovy, and so you can go up to 7.2. The 7.2 gives you 20% weight loss. So again, if you look at the injections are once a week. So some people prefer that because they don't have to take a pill every day. The pills are an everyday pill, and you do have to take the pill and wait for 30 minutes before you eat or drink anything else. And so that is important, to do that, to get the good absorption. As I talked about, this is a protein molecule, and to get it absorbed into your body, it has to be on an empty stomach, and you have to wait for 30 minutes to really get the full benefit of that medication for the pill. But the injection is once a week, and you can see the price of that for 15% weight loss with a 2.4 milligram dose is $12 a day, or $3.49 a month. And then it's $3.99 for that 7.2 milligram dose. So another dollar a day to get potentially another 5% weight loss. So that is, pretty good there to get more weight loss. You can do that at a smaller price. Ozempic is shown on the left. Ozempic is our medication. Same, it's all semaglutide. It's all the same drug in all of these different instances, right? But Ozempic is approved for patients with diabetes. But for some people, if they're taking a lower dose, if they respond to a lower dose of this medication, we can prescribe the Ozempic and they can pay cash. It is $4.99 for the 2 milligram dose, which has 8 milligrams of medication in one pen. So again, at the 2 milligram dose, it would be $16 a day. So you'd be better off doing the Wegovy if you're up at that higher dose. But if you're responding to lower doses like 0.25 or zero point 0.5, and some people might call this microdosing. We do not like that term in the world, in the professional world, because it really is just the dose that you're responding to, right? Microdosing is a marketing term by certain people out there to try to get you to buy something. But really, what we're talking about is a smaller dose. You may respond to that. And if you respond to that and you can take a smaller dose of this Ozempic, we can make that 8 milligram pen potentially last for 6 or 9 months with those smaller doses, and therefore you're spreading out the cost over. This is $4.99 for one of those pens, which is 8 milligrams. And if you're taking a very small dose every week, you're going to make that pen last a lot longer. That price is going to go down. All right. So tirzepatide, this is the cost of access of tirzepatide, which is Zepbound. And this is on the Lilly Direct, or you can get it at your normal pharmacy as well. And you can do that in the quick pen, which is shown here, multi-dose pen. There's a unit dose pen. This is what's mostly covered by insurance. So one dose each week, one pen. This quick pen you use multiple times, so it has multiple doses in it, like the Ozempic pen as well. And then there's vials as well, and you can see the different cost. The 5 milligram dose is $3.99 a month, which is about $13 a day for that same 15% weight loss. 15 milligram dose for 20% weight loss is $4.49, and that's $15 a day if you're having to go up to that 15 milligram dose. And the unit dose pens, these ones that insurance typically covers, they are $4.99, so you can get them even for a cash price if you prefer to just take it in that unit dose. And this is the newer medication that orforglipron, and it is multiple doses here, 1, 2, 3, 4, 5, 6 doses. Most people are going to need to go up to the top dose, which is 17.2, to get that average weight loss, which is a little bit lower, around 12%. And you can see the different costs for each of these, and it's about $10 a day when it comes down to it. So very similar to the oral Wegovy. The advantage of Foundayo is you can take it any time of day and you don't have to fast. So it's our first small molecule GLP-1. It's not actually a long protein peptide that we talked about. It's a small molecule. And so because of that, it gets absorbed a little bit better and you don't have to fast. And here I've just broken out a year's cost of each of these medications. So the cost for the whole year of these different drugs in dollars per day here for an average of 15% weight loss. So most of these medications, including 5 milligrams of tirzepatide, will give you 15% weight loss. So you can see that the oral semaglutide and the orforglipron, about $9 a day is sort of your cheapest way to lose 15% of your weight, so to speak, if you are having to pay cash. Same with the 20% weight loss. If you want a 20% weight loss, you can get that with 15 milligrams of tirzepatide or 7.2 of semaglutide. And right now, at least, because there's a little bit of a lower price on one of the doses of Wegovy, you can do that for a little lower, that 20% weight loss with that semaglutide. We can also do something called click counting with both the Ozempic pen that you saw earlier and the Zepbound multi-dose pen. This is off-label and not approved by the FDA. But for example, if you have a 15 milligram pen, it's $4.49. You can see when you dial up the dose, you would normally dial it to the 1, and that would be one dose of 15 milligrams. But if you're taking 5 milligrams, for example, with this pen, you can count the little clicks. If you look closely, there's little lines on this pen, and it makes a little clicking sound as you turn it. So you count 20 of those lines, and that's approximately a 5 milligram dose of the 15 milligram pen. And then that one pen is going to last you 3 months instead of 1 month. So now you're paying $1.49 a month on average, or $5 a day for that 15% weight loss. So we do have some of these tricks that we use, so to speak, in order to help people save money if they want to do so. Next, I'll just cover quickly. I know I got to get going here in the interest of time so I can answer your questions, but naltrexone bupropion is called Contrave. And again, I mentioned that on average, it has about an 8% weight loss. But 30% of people, 30 out of 100, can see a 15% weight loss, especially if they combine it with intensive behavioral therapy, like working with a dietitian and working on RX food, for example. That would be a way to get that, closer to that 15% weight loss out of this medication when you combine those things together. It can also help improve mood and motivation and focus because bupropion is a medication for that. The biggest side effect can be nausea due to the naltrexone. Not as bad as the GLP-1 nausea, so not quite as many patients have nausea from this medication, which is good. And also some people feel a tremor or feel a bit jittery from this medication. So that can be another side effect that people don't like. But the cost of this drug is $99 a month cash, and we can also prescribe the individual drugs, as I mentioned, the bupropion, naltrexone, and a lot of times insurance will cover that. So if you have a copay with your insurance, let's say you might pay, $10 or $20 for each of those, that's about $40 for both of them separately, or $99 if you want to get them combined in one pill. So that's about $3 a day for the cash price, even at the $99 point for taking a medication like this. They can help you get to that 15% weight loss, even more so than your diet and exercise alone. And then this is just kind of a busy slide, but what I want you to focus on here is in red. So weight maintenance with orforglipron or Foundayo, that's that new once a day pill. If you're currently taking Zepbound or Wegovy, if for patients in this trial, it was called the Attain Maintain trial. Here's a picture of the publication just recently. In patients that had lost weight on Wegovy and then they switched to Foundayo, they over the course of a year, they pretty much maintained their weight. So when they switched, they were at 209. And at the end of a year later, they were at 211. So they had gained 2 pounds back. They started at 250. All these people started at about 250, 255. Okay. So they got down to that 20% weight loss. And then that 50-pound weight loss, but they gained just a little bit back if they were on the Wegovy and switched to Foundayo. If they were on the Zepbound and they switched to Foundayo, they gained about 11 pounds back. And that was because those patients lost a little more weight. So they were here, when they started it, they were at 200. So they had lost 55 pounds of weight and lost a little more weight, but gained a little more back when they switched. And I just say that because you can switch to Foundayo. Foundayo is $299 a month versus that 15 milligrams. If you were on 15 milligrams of Zepbound, you'd be paying $449 a month for that 15 milligram dose. So if you switch to the Foundayo, you're going to have a savings there per month, to be able to maintain that weight that you lost. So three conversations we have when we start with patients. We want to protect your lean mass and your bone density. That's why we want to really pair our therapy with adequate protein and the progressive resistance training, especially if you're a midlife woman. So again, really working on maintaining our lean mass and maintaining our bone density. We're going to plan for people to have GI side effects with a lot of these medications. So we're going to help you manage those and help you be there for you so that we can provide insights with our app and with our clinicians to be able to help you manage that nausea with behavioral things or with other medications, etc. And we're going to treat this disease as chronic. If you stop medication, roughly 2/3 of the lost weight returns within 1 year. So obesity is a chronic condition. Stopping medication, you're going to expect to regain weight. It's not like you can't stop and you can try to not regain it back, but like that tug of war, right? If you take away a guy from that other side or a girl from that other side, you can put that weight back on. And this is that data to show that. If you look at this graph in the far left-hand corner, these patients are on semaglutide, and at about 20 weeks here, they switch them to placebo, half of them. They don't know they're taking placebo. And the people that switch over to placebo, they start to gain that weight, and they get almost back to the weight that they started at. Not quite, but this is still going up. So if you continue this graph over time, you would expect it to go back to where the patient started. But you can see if people continued on the drug, they continued to lose weight. So again, if we take away the treatment, if we take away the extra tug of war over there, the extra strength over there, we're going to bounce back towards that weight regain. And that's biology. That's not your fault. So the average weight loss at 18 months for a person who weighs 235, pick that because that's kind of the average patient in the clinical trials. On each of these drugs, you can see here, this is for a patient who hasn't started on any therapy. they would be expected to lose about 20 pounds. On Contrave, this is at the end of 18 months, right? On orforglipron, about 30 pounds. Oral Wegovy, about the same, 33 pounds. Injectable Wegovy, maybe a little bit more, 35 pounds. And that's at the 2.4. So if we bump that up to the 7.2, we can get close to that tirzepatide 15 milligram, which is that 50-pound weight loss there. So again, depending on what you're looking for and to balance that cost effectiveness, we have these discussions to help you get to your goal. So last but not least, a little bit about knownwell. We're delivering results at scale. We're 50 states for telehealth, but we have clinics in these locations and soon to be a clinic that I didn't put out here in September, which is in San Diego. On average, our patients have lost 15% of their weight. When we've done studies on our patient outcomes, we have 50% less muscle loss versus the benchmarks versus the studies, right? So less muscle loss than what's studied. We have 93% sustained weight loss. So 93% of our patients sustain their weight loss over 2 years. And we have a 90 plus net promoter score. That means that that our patients overwhelmingly recommend us to their friends and family. We have an app that's loved by patients to help you, with your journey, so you don't have to navigate one of these clunky, portals from the EMRs that we work in. We work in an EMR, we work in Athena, so all your information is in a HIPAA protected electronic medical record that we work in. But you get to also be in an app that's also HIPAA compliant in order to, send that data back and forth, so you can just see things a little bit more more in a better way than the portals that you usually have. But don't just take our word for it. You can read our patient reviews. Here's some of them there. You can also go on Google and read our Google reviews. We have a lot of positive patients that are very happy with our care. This is some pictures of our clinic with very size appropriate furniture, so people don't have to feel, like they're trying to fit into something that doesn't fit them. We're here for people of all body sizes. So how to get started with knownwell? You can visit knownwell.co, that's our website, or you can scan this QR code to book your visit today. You can book everything online. You can pick, your clinician. You can pick the time of your visit. We'll ask you to do a small intake questionnaire in order to learn more about you before you come in, and then we'll meet with you. We have a non-stigmatizing approach. We're there for you to meet you where you're at and what your goal is. Even if your goal isn't weight loss, right? Your goal may be to improve your metabolic health. That's a very valid goal, and we have ways of helping with that. And as well as with weight reduction for patients that want that as well. We have a comprehensive care team. We follow you up regularly. We converse with you, and we have positive outcomes that we've shown there. And so that is the end. Please follow us at knownwell Health on Instagram or Facebook and LinkedIn. And I'm gonna take your questions here. Let's see. Okay, so just a reminder that Hanover's insurance does not cover GLP-1s for weight management. The only exception is diabetes, so doesn't cover it for sleep apnea and other indications. So only for diabetes is what you have coverage for. Are these options available for someone breastfeeding? So that's a great question. The medications such as Zepbound and Wegovy, the injectable forms, not the oral forms of medications, but the injections I showed, can be used in certain circumstances during breastfeeding. They are large peptides. I showed you kind of that picture of them, right? And because they're large peptides, and you're injecting them, they don't tend to be excreted in breast milk, and that's been studied and shown. So that because they're large molecules, it's hard for large molecules to get places. So it's hard for them to get into breast milk. And so for some patients, they may make that choice, that shared decision-making choice, to start on a medication while breastfeeding. However, I don't recommend it early on because, if you reduce your calories, I mean, naturally, that's what you will do because you'll be less hungry. It can decrease your milk production. So again, you don't want to do that in the beginning. And if you're worried, like you don't want to do that if you don't want to be done breastfeeding by chance, right? If you don't want that production to potentially go down. So that's the side effect of that. All right, let's see if there's any in the Q&A. And I saw some people had their hands up. I don't know if people still have their hands up. If you have your hand up, I'm not here. Somebody has their hand up. Hannah, you have your hand up. Do you want to talk? Or did you just raise your hand like, didn't mean to? That's all right. If you don't want to talk, that not necessary. Let me see what other questions I have here in the Q&A. All right. Where's my Q&A here? All right, here we go. Um, The prices are better than what they used to be, but this is still a huge expense for families when it could be covered by insurance. Do doctors at your practice send in letters to the insurance company telling them the medical necessity for this for people who have thyroid disease or PCOS? Great question. We really can't do anything. If you don't have coverage, it is coverage is chosen by the employer today. And if you don't have coverage for weight management, there's no really exception to that. That's the downside. If it's exclusion from your plan, then writing a letter doesn't do anything. We can't write a letter for something that's excluded. You can only write letters if, for example, something is covered and then there is you like fill out a prior authorization and you don't get it covered, but we think they were wrong in making that determination. We can do an appeal on top of a PA. But when medications are excluded for weight management, we really can't, send something to the insurance company because the insurance company is just it's excluded. There's no help there, unfortunately. Hopefully, we hope that when these medications get less expensive overall, that more people, more employers will be able to afford them. The idea that they are expensive means that it would be very expensive, and then the employer would have to potentially raise your premiums, et cetera. It's very costly, unfortunately, at the current prices, around, say, for example, 449, when a lot of our medications in the world are $100, let's say, right? Which is a lot cheaper. But definitely in the future, these costs are going to come down greatly, hopefully, and that's going to be something that'll be, I think, I think it's only a matter of a few years, a couple years, for the prices to really come down. I'm coming from a district that did cover the GLP-1 and have been on tirzepatide for 2 years. Now that I'm in Hanover and it is not being covered, I'm concerned with having to stop the GLP-1, not only with regaining weight, but losing the metabolic benefits, right? Are there any solutions? Yes, well, like I said, I think depending on what dose you're on, there have been some data. For example, I showed the data with Foundeo. You can manage things with Foundeo. It's $2.99 instead of $4.49. Some of our patients will increase the interval of their dose. So if they want to try to maintain their weight on, for example, Zepbound, if that's the case, if they're on 15, they might take it every 10 or even 10 days or every 2 weeks even, and then stretch it out, right? So that 449 a month for the 15 milligrams Zepbound is now lasting for 2 months, and then therefore it's 225, which I realize is still an expensive feat for many people. But again, if it's around that $10 a day, if you can also think about other ways I can try to save money other ways on that $10 a day as well. So yes, good question. All right. Well, we're at time. So thank you so much for attending. It's great to have your attendance, and sorry for the little snafu in the beginning. And please reach out if we can be helpful because that's what we're here for. Thank you so much.